morning, and thank you for giving me the opportunity to present today. Mike? Fine. I thought I'm loud enough. As I started yesterday, I'd like to just thank Lior, Inbal, Yarden, the whole Chamema. They've really been pivotal into our guidance in our device and the process. I'd like you to hear the process from Josh Mekover to see how the process can really be instrumental in development. Ergo GI solutions that make sense. First and foremost, my team. I never act alone. Myself, Stéven Shama, to my right and my left are two of the most experienced and, in my opinion, excellent endoscopic nurses that I've ever worked with. Gerard Aguila and Yassine Abouvassel, who work with me in the trenches day in and day out and have really been instrumental in developing our concept, our idea, and our solution. As gastroenterologists, we're frequently called for patients who either suffer from intractable abdominal pain or, in the emergent case, bleeding. The most common causes of upper GI bleeding is generally ulcer disease, which can be an ulcer in the esophagus, the stomach, or the duodenum. And we generally follow up with the complaints with an upper GI endoscopy or a flexible endoscopy. It's basically a flexible scope with, at the end, has a camera. There's a small channel that goes within the scope and enables us to see and treat. However, when since the patient's on the left lateral side, as you can see down here in this picture, there's about 60% of the stomach is in the dependent portion. This is about a sac, and things tend to accumulate there. Blood, food, blood clots, and blood clots can be very viscous. They can be as small as 3 or 4 millimeters, as big as 8 centimeters. We have a 2.8 millimeter channel, and that tends to get obstructed. If we can't see the problem, we can't treat the problem. If we can see the problem, we have several modalities that allow us to treat the problem. We can either inject a sclerosing agent or something that causes vasoconstriction, like epinephrine, followed by thermal therapy to ablate the vessel that may be bleeding, or mechanical therapy in hemoclips or other larger clips to close the vessel. But it all surrounds in visibility. If we can't see, we can't treat. I'm going to further explain the unmet need, or the need that we chose to set out to solve with the clinical case. Short, and it should become self-evident what our unmet need is. This is Jacob. Jacob is a 78-year-old male with ischemic heart disease, diabetes, and hypertension. He's brought to the emergency room by his daughter, who's somewhat concerned because Jacob has just vomited blood or had hematemesis. His labs show that he's lost about 40% of his total blood volume, even though he seems pretty stable, and he's whisked away to an emergent endoscopy. During the emergent endoscopy, the endoscopist puts the scope down into the stomach. It's full of blood and blood clots. He can't see much, but he can see that there's no act after sitting there and looking at all the places, the common areas that may be bleeding. There's no clear, discernible active blood loss. Things seem pretty stable. The patient's pretty stable. He can't really see anything to treat, so the election is to treat the patient medically and to come back at a later date. Over the weekend, a patient gets transfused 3 units of blood, remain fasting for 2.5 days, which is not fun. I do it for a half a day and I'm cranky. And we come back and repeat the endoscopy early Sunday morning. When we get to the stomach, we see a pool of blood clots and blood that looks a little fresher in the stomach, so we assume that something more active is going on here. But we're still left with the same problem. We don't have a way to clear out the blood clots from the upper GI tract in an easable fashion. There are no devices that are deemed for this process or this problem. We're basically limited by a 2.8 millimeter channel, which is found in the endoscope that we find in every endoscopic suite in the world. We are lucky enough in Baylinson to have a second scope that has a 3.7 millimeter channel, yet it is limited by suction and the power, and not every endoscopy suite in the world has this capability of having a larger scope. After about an hour and a half of using tools from different corners of GI, we're able to clear the area and see that there is a visible vessel up by the G junction, the gastroesophageal junction, that was bleeding. And with the devices that I showed before, injection, cautery, and clipping, we're able to stop the bleeding. And because we're able to clear all other areas of the GI tract using an hour and a half of work, delayed anesthesia, prolonged anesthesia, we're able to say that this is the source of the bleeding. 2 days later, patient goes home feeling much better and a much better state. Jacob isn't alone. In the US, 330,000 people approximately undergo upper GI endoscopy for bleeding, and roughly 15 to 20% of them will go through a second link endoscopy because we don't find the cause of bleeding. That's roughly about 50,000 people a year will have to go through another endoscopy, prolonged hospitalization, and prolonged use of resources. Which brings us to our unmet need, which is we need a means of breaking up clots, clearing the upper GI tract to enable us to see better so we can treat better. This will reduce recurrent procedures, reduce hospitalizations, length of stay, and hospital expenditure. Once we hit our unmet need, we like to look at what solutions do we have today. These are all pictures of devices that we use for other things in GI, a net to collect polyps after we resect them, a basket we use in the biliary system, snares that we use to do resections, and there's no dedicated device for removing blood clots or breaking up blood clots from the upper GI tract and enable us to treat. When we look at the market, we're looking at global GI endoscopy market, roughly $4 billion in 2015, upwards of 4.6 in 2019. Where upper gastrointestinal procedures cover about 70% of the market, where instruments and accessories take about $1.1 billion in 2015. So there is a market for accessories and devices in the GI endoscopy world. If we just go back to Jacob very quickly, he had to go a second look endoscopy. As I said, the cost of preventing a second look endoscopy is roughly between $13,000 and $15,000. If we couple that or multiply that by the $50,000 that occur on an annual basis, we get to about a $650 million per year savings if we can completely eliminate the need for second look endoscopy, or at least reduce it. So we then move to need specifications, the next step in the process to kind of figure out what we need to create, how we need to solve, and essentially we need something that removes blood clots. We need something that does not limit our maneuverability. We're stricter on size. We can't make a big tube to suck out clots because it won't pass the esophagus. And first and foremost, it needs to be safe for our patients. What we'd like to have is something that enables us to clear and treat at the same time, which is the most ideal tool that we can use. So we sit down and we pull all brains, cardiologists, gastroenterologists, anyone and everyone who may be in the room. We get loose and we basically throw out any idea, any concept that comes to mind, things from the kitchen to the street to the office to the bathroom, you name it. It came out, and then we group them together to figure out which direction is best we come in and where our ideas may come in. And then our product designer of the בחממת helped us, Yarden Moore, sitting in the crowd, but basically draw out a bunch of options where we just think more in detail of what may work through the endoscope, outside the endoscope, and we were able to get to our final product, or not our final solution, but a solution that will go, that we'll take forward. It's in several steps or several several parts. This is a cap-based external channel. It has a diameter of 4 millimeters, cut back a little bit to aid in introduction to the upper GI tract. This is a cap we do use currently today, and it adheres to the scope quite nicely. And then it would adhere also by the upper gastroscope, but near the top by the working channel. This is the endoscope that we use schematically. It has a T-shaped or a Y-shaped pattern here. It enables us to use it both as an instrument accessory channel and for suction, and increase our suction almost twofold because our native channel is about 2.8 millimeters. The second device is what we call a Clot Trimmer. It reminds me of something we use to cut the grass, but it's 2 wire filaments, sheath-based, to allow for safe introduction through the scope and into the patient. It can be screwed on and adhere to the scope either through the accessory channel or through the channel itself, the therapeutic channel. We have a tip location lock that enables us to tell us exactly where the tip lies, either zero right flush with the scope itself or out 1, 2, or 3 centimeters under direct visualization. It is the spinning is operated by a battery. A little closer, because safety obviously is in keystone and paramount. The first wire is a polyethylene or rubber based, so even if it comes into contact with the gastric mucosa, it will not traumatize it. Followed by a metallic or nitinol wire that will increase the shearing force of the device and enables to break up any clots that it comes in contact to and allow for prompt evacuation by the accessory channel. This is what it looks like if it's put through the accessory channel itself and attached to the scope, and this frees up the therapeutic channel of the gastroscope to help us treat once we find the source of bleeding. This is a schematic of what it looks like in real life. This is what our gastroscope looks like. This is how it would look like on the outside, adhering both at the top and the bottom, and also one or two times in the middle to prevent tangling with our scope and not limiting maneuverability. It's provisional patent pending submitted. These are looking at the competitive landscape. This is the closest competitor, but it uses the channel, it just bypasses the second part of the scope, but it doesn't aid in increasing too much of the suction power. These are caps that increase visibility, but has no ability to help us clear out debris. This is a rotating blade that is quite traumatic to the mucosa and not deemedly safe, and hasn't really picked up traction in this space or space of resections, which was thereby where it was created. We hope to utilize we're a product of the Chamema. Chamema, as I said, was instrumental in this whole process to where we are now and where we're going. We are currently working with a design lab, working on our active prototype, and hopefully by Q2 or Q3 of 2022, we'll hopefully be on to clinical testing. We hope to, with our products, eliminate the need for second look endoscopy, because it's extra and it just prolongs hospital stay, hospital expenditure, comorbid risk, and complication risk. With the help of the Chamema and the help of everyone going forward, we hope to get this device in every endoscopic suite in the world, because every endoscopy suite has a basic endoscope. If I had a loved one or myself was undergoing an emergent endoscopy, I would want my gastroenterologist to have all the tools in order to solve the problem the first step around and not have to return the second time around. So hopefully we can do that in the next year or two. Thank you.